Take one. So today we're going to be talking about anisocoria. Coria means pupil, iso is same, an is not. So not the same size pupil. When we're dealing with anisocoria, we want to figure out, is it the bigger pupil that's the problem, or is it the smaller pupil that's the problem? In order to test this hypothesis, we're just going to shine a light into the eye. If the bigger pupil doesn't constrict, that's the problem pupil. However, if the anisocoria is greater in the dark, that means the little pupil is not dilating. So testing the light reaction and the size of the pupil in the light and in the dark is how we determine whether the anisocoria is from the smaller pupil or the larger pupil. So let's just take the first scenario, which is the light, and then we'll do the dark. If the anisocoria is greater in the light, that means the bigger pupil is not reacting as well to light. And that is a problem with the parasympathetic nervous system, mediated by the third nerve to its ganglion, the ciliary ganglion, and then the postganglionic fibers, which go to the iris. So when we have a larger pupil that doesn't react to light, the problem is somewhere along this pathway. The first thing we want to make sure, of course, is that it's not a third nerve palsy. And you can easily do that by looking for the lid and the motility. So if the lid and the motility are normal, it's extremely unlikely that a dilated pupil alone would be a third nerve palsy. And so one of the things we'd like to do is make sure that it's not something in the iris or the ciliary ganglion. In order to make sure it's not the iris, we're just going to look with the slit lamp examination. So we're going to be looking for iris transillumination defects, sphincter tear, irregularity of the pupil, posterior synechii, uveitis, something wrong with the muscle. If it's not the muscle, then it's down to the ciliary ganglion or the connection between the ciliary ganglion and the muscle, called the neuromuscular junction. The most common cause of the neuromuscular junction to be affected is if someone has put drops in your eyes. So if you've been given a topical dilating agent, a mydriatic, it'll dilate your pupil, it won't react to light, there'll be nothing wrong with your slit lamp examination, and it won't react to near as well, and that is pharmacologic mydriasis. We can test this hypothesis by applying pilocarpine, a direct-acting parasympathomimetic, at a high dose, 1% or 4%. And if we put 1% pilocarpine into a pharmacologically dilated pupil, it won't constrict because it's blocked. The alternative, of course, is that it's the ciliary ganglion or the postganglionic nerve, and that we call a tonic pupil. When it's idiopathic, we call it adhestonic pupil. And the way to test for adhestonic pupil is, if the light reaction is poor, the anisocoria is greater than the light, then we test the near reaction. In a ciliary ganglion lesion, the near reaction will be good, and that we call light near dissociation of the pupils. The light reaction is good, the poor, but the near reaction is good, light near dissociation. And that light near dissociation, in association with a tonic reaction at near, tells us that it's the adhestonic pupil or some other tonic pupil from surgery or from a tumor in the orbit or whatever is the cause, but most of the time it's idiopathic, which we call adhes. We can test this theory by putting in low-dose pilocarpine, but instead of 1%, 1/10% pilocarpine, and in a patient who's had denervation from the ciliary ganglion from adhestonic pupil, the application of low-dose pilocarpine, 1/10%, will cause the pupil to constrict, versus the normal eye, which shouldn't constrict. So this will demonstrate denervation supersensitivity and confirm the hypothesis that it's the tonic pupil, and if it's idiopathic, adhestonic pupil. That is pretty much the parasympathetic side of the equation. So your main job, make sure it's not third nerve palsy, look at the slit lamp at the iris, confirm that it's not pharmacologically dilated by the history, test the theory with pilocarpine 1%, and if it's the adhestonic pupil, look for light near dissociation of the pupil, sector paresis, and you can test pharmacologically with pilocarpine 1/10%. On the other side of the equation is the anisocoria is greater in the dark. If the anisocoria is greater in the dark, then what we're dealing with is a sympathetic nervous system problem or a physiologic anisocoria. And the way to tell the difference is to look for a dilation lag. A dilation lag is a fancy way of saying the smaller pupil doesn't dilate as well as the normal pupil, and there's a lag in time for that dilation to occur. So the presence of the dilation lag is seen when we turn off the light, the anisocoria is a lot different than it is after 10 seconds because there's a lag in the dilation. So the lag allows the dilation to catch up in the sympathetically denervated Horner syndrome people. If you see a dilation lag and the anisocoria is great in the dark, then we're going to be looking at the lid for the ptosis. But unlike the ptosis in a third nerve palsy, which can be quite variable from partial to complete, the ptosis in the Horner syndrome pupil is usually only 1 to 2 millimeters. There's also an upside down ptosis from the equivalent in the lower lid of the Mueller's muscle. And so we really have a little bit of ptosis and upside down ptosis in the Horner syndrome, 1 to 2 millimeters. Once we've confirmed that clinically this looks like a Horner syndrome, then we're going to try and test the integrity of the sympathetic nervous system, much like we tested with pilocarpine for the parasympathetics. We're going to use direct acting and indirect acting sympathomimetics. The sympathomimetics that we're going to be using are topical cocaine and aproclonidine. So let's just start with the direct acting sympathomimetic. The direct acting sympathomimetic, aproclonidine, is an alpha agent. It has differential activity for alpha 1 and alpha 2. Under normal conditions, the alpha 2 effect predominates, and if we put aproclonidine in a normal pupil, it will either stay the same size or get slightly smaller. If, however, we have denervation supersensitivity from a Horner syndrome, the alpha 1 postsynaptic effect will predominate, and that smaller pupil will dilate. And this will result in a reversal of the anisocoria or dilation of the Horner side pupil. So aproclonidine can be used to detect whether we have a Horner syndrome or not. There are 2 indirect sympathomimetics that we could also use, which are much more difficult to get and maintain because they're controlled substances. And those are cocaine and amphetamines. Cocaine works by inhibiting the reuptake of norepinephrine at the neuromuscular junction. And so if we put cocaine into a normal pupil, it'll dilate. But if we put cocaine into a Horner syndrome pupil, it won't dilate as well because there's no norepinephrine in the junction to allow it to dilate. And so the anisocoria will be greater than 1 millimeter after we give the cocaine compared to the pre-cocaine test. Amphetamines, hydroxyamphetamines, are also indirect acting sympathomimetics, but it works by releasing the norepinephrine at the neuromuscular junction. And therefore it can be used to tell whether we're dealing with a first order, a second order, or a third order neuron Horner syndrome. And that we call a pre versus a post-ganglionic Horner. So the first and second are pre-ganglionic, and the third order is post-ganglionic for the Horner's pathway. And as you know, the Horner's pathway begins in the hypothalamus, descends posterior laterally in the brainstem, down to the ciliospinal center of Budge in the spinal cord. That's at C8-T2 level. Exits white rami over the apex of the lung and up the sympathetic chain onto the internal carotid artery, and then travels into the cavernous sinus, a short course on cranial nerve 6, and then 5 to reach the target organ, which is the lid and the pupil. So it's a very complex oculosympathetic pathway composed of a first order neuron from hypothalamus to ciliospinal center of Budge in the spine, a second order neuron over the apex of the lung and onto the carotid, and then synapse at the superior cervical ganglion, where it becomes a third order neuron to the cavernous sinus, 6, and then 5. So if we give the indirect acting sympathomimetic hydroxyamphetamine, which stimulates the norepinephrine at the junction, if the third order neuron is broken, the pupil will dilate as well. If, however, it's the preganglionic Horner syndrome, the first or second order neuron, if we give the hydroxyamphetamine, it will dilate. So once we've confirmed with aproclonidine or cocaine that it is indeed a Horner syndrome, if we give the amphetamine and it dilates the pupil, then we know the problem is preganglionic Horners. If, however, it doesn't dilate the pupil as well, that is a postganglionic third order neurons. Now, in reality, we probably don't need to do all of these drops. We're just going to image the entire sympathetic axis from the hypothalamus all the way down to thoracic T2 in the chest with a combination MRI, MRA in the outpatient setting, head and neck, and in the emergency room, CT, CTA, head and neck, because what we're looking for is carotid dissection in the acute setting. So that's just a very quick review of Anisocoria and how we deal with the parasympathetic and the sympathetic side. And you can use the drops to confirm what you're looking for, but it's not necessary. Most of the time we can do what we need clinically. So the question came up, how does aproclonidine work? If we have a presynaptic junction, in the sympathetic nervous system, we have alpha-2 receptors, and on the postsynaptic receptor, we have alpha-1 receptors. Under normal circumstances, the alpha-1 postsynaptic receptor and the alpha-2 are antagonistic. This is a negative feedback loop that allows us to turn off too much sympathetic activity in the junction. Aproclonidine is preferentially an alpha-2 agent. And so when it binds to the presynaptic alpha-2, it actually causes the opposite of what you think it's going to cause. Even though it is a sympathomimetic, which should cause the pupil to dilate, because it is an alpha-2 agent, it actually causes the pupil, in a normal pupil, to either get slightly smaller or no change. If, however, you have denervation of the sympathetic pathway, then there won't be any release of norepinephrine. There'll be upregulation of the alpha-1, and that is a postsynaptic upregulation, which we call denervation supersensitivity. This denervation supersensitivity will allow aproclonidine to have an alpha-1 predominating effect now. And when the alpha-1 effect occurs, the pupil will dilate. And that means in a Horner syndrome, if you put aproclonidine, it might reverse the anisocoria. The small pupil becomes the big pupil, and the big pupil gets slightly smaller. But the endpoint of the test is dilation of the involved Horner syndrome myotic pupil.